How are you going to push out your baby? Did you even know that you need to push at the very end of delivery? Today, we're going to talk about all those important things to know. And it's really important that you learn about pushing from an expert who's someone who's done it with a lot of different people. Hello, I'm Hilary. I'm the pregnancy nurse. I've been a nurse since 1997. I have 20 years of labor and delivery experience, and I've helped thousands of people push out their baby. So I really am an expert on this one. And I think I'm really going to help you understand how it might work for you. First off, what is pushing? So during labor, your uterus is actually going to contract to do all the things that it needs to do to get the baby's head through the cervix. Now, once the baby's head is all the way through the cervix, then we can start pushing. Because your uterine contractions most often is not enough to get baby to earthside, to be breathing the air with us. And so you're going to need to push, just like you do with a BM, the baby out. Now, some of you are thinking, oh my gosh, Hilary, am I going to have a BM at delivery? I have a whole post on how to avoid having a BM at delivery, but the truth is you might, and it is not unusual. Nurses are totally ready and prepared to take care of it, and a lot of people don't even know that they ended up having one because we are all good people who understand that you're using the same muscles. So you use those muscles to push out the baby. Now, average pushing time on your first baby is around 2 hours. So it's just something you need to know. I know a lot of people think, oh, I got to 10 centimeters, that baby's just going to come right out. No, that is when PE class starts and we're going to start pushing. Now, what do studies show is the best way to push out a baby? I gotta say that online, especially with physical therapists, I see a lot of misinformation about this whole topic. So I'm excited to dive into the actual studies, not an article that was written by a physical therapy magazine, actual studies on how pushing works and what can be the best thing for you. Okay, one of the first things that people study is delayed pushing versus initiated pushing. So when you get to those 10 centimeters, we can start pushing right away. Or if baby is still high in the birth canal, we can let that uterus do some of the work, maybe gravity, maybe we change your position frequently to help baby come down into the birth canal so that we're not having to push as long. Now, studies seem kind of mixed on this one. There is an increased risk for infection for baby in the womb, just because you can imagine the longer it hangs out in there, the less good it is. There's also an increased chance for hemorrhage. So we don't want to let you just hang out there forever. Sometimes when the baby's high, your provider or your nurse will say, hey, let's delay pushing for about an hour, and then we need to get started if baby's head hasn't come down after that hour. Now, a lot of times people who have an epidural are able to wait that hour. Now, if you're going naturally, then sometimes you feel that urge to push and you can't really avoid it. And so you just start pushing, and that's okay too. With that, you'll see a lot of providers who are saying we don't delay pushing at all, but reminder, it is always up to you. If you ask your nurse and the baby is still super high and you don't feel an urge to push at all, you can say, you know what, I would like to wait a half an hour. Can we change our position? Can we sit straight up? Can we squat? What else can we do to see if this baby can come down a little bit with my uterus doing the work rather than me having to engage my ab muscles, which I never love to do. Remember, it is always up to you. Even if your provider says, oh, we need to start pushing right away, ask them more about it. Ask them the risks and the benefits that they're seeing that are telling them that you need to push right away, because I will tell you that sometimes it's a kids' choir concert. So just talk with your provider to decide what is best for you, because that's important. That being said, there really are times that we really need you to engage and start pushing. Don't just think, oh, I can delay it forever. No, that's not going to be the best thing for you or for the baby. Now, one of the next ones I see vilified a whole lot on social media is directed pushing, where we say, okay, pull in your breath, we're going to count to 10 and push, or just you pushing however the heck you want. The studies really do not show that one is better than the other. And this really depends on the person. And so I always try to do both ways with my patients, and they could just decide what worked for them. A lot of times they were asking me which one had the baby descend. It's really important to know that you need to give long pushes, because this is definitely a 2 steps forward, 1 step back type of a phenomenon. As you're pushing baby down into the birth canal, they will come out. And then when you're done pushing, they will suck back in. So as you can imagine, if you're just giving short pushes, this is all you're going to get is baby kind of moving back and forward. You do need some longer pushes to kind of push that baby towards the birth canal. And some people find that's most effective when we count to 10 or whatever the heck they want it to. If they only want to count to 8, let's do it. But some people really need that goal to be able to push for a long extended period of time, because if they're just doing it spontaneously, can't push for a long period of time. They kind of need that goal line to reach for. And again, some people absolutely hate the count to 10 thing. So if your nurse is like, we're going to count to 10 and it's driving you insane, then say, hey, I would rather try either just counting to 10 in your own mind or just doing it on my own. Let's see how that goes. And a lot of times it was the one that the person liked the most that really helped the baby progress the most. That's just how great Mother Nature is to us, which is awesome because she has been torturing us for the last 9 months. But I really found that to be true. What people felt the best about often worked the best. And I gotta tell you, for a lot of people, that is counting to 10, especially if you have a long time of pushing and things are not progressing as quickly as we would hope. Quick reminder, first baby usually is around 2 hours. Then subsequent babies, less. Sometimes, we just laugh your baby out. Sometimes your doctor's not there and we like, we have got to stop laughing or this baby is going to come out. So it's really different on subsequent babies after your first, unless you're like me, where my next baby was 1.5 pounds bigger. And that was, again, another 40 minutes. But still was better than the first. Okay, now for a long time, you've heard nurses say, okay, grab that deep breath in, and then push. And at that point in time, you close your glottis, which means no noise. Your glottis is a thing at the back of the throat that stops air from coming out your mouth. And so you're pushing all that air down onto your uterus. This is versus open glottis pushing, where the glottis is not open and you kind of have a moan during it. Now, we are definitely not looking for a high-pitched scream during this point in time. If a patient is doing the high-pitched screams, a lot of times we'll redirect them just because usually high-pitched screaming does not mean that you're pushing down. You're putting a lot of more of your effort into your vocal cords and things like that. So we're looking for like low moans, ooh, that type of a thing with open glottis pushing rather than screaming. And again, there are so many people online who are like, this is the way to push. But if you look at the studies, it really shows the open glottis versus closed glottis pushing. It really depends on the patient's preference. So I, again, would encourage people to try both different ways, and then they could choose which one they liked, or they could vary it. They could take one where they did closed glottis pushing, and then the next one they did some open glottis pushing. So you can do whatever works for you. Don't feel like you have to stick with one type of pushing just because that's been working so far. I think it's really important to mix it up. The final one is the position that you push in. Again, the studies really show that pushing in the position that works best for you works the best. Now, if you have an epidural, your positions for pushing are going to be limited. I a lot of times see people on social media saying, oh, get on all fours with your epidural. And for some people with a light epidural, that is possible to be in that position for a good period of time. But for most people, if we get you onto hands and knees, you make it about 2 contractions and then your hips just start to hurt so much that you need to be in a new position. Your muscle control is just not there to support your body on hands and knees for a long period of time with an epidural. That doesn't say I haven't used it. I can sometimes use like a birth ball to kind of help us, but because your baby is right under there are limitations in what we can use to support you on a hands and knees position. Now, studies have shown that decreasing tears happens most often with hands and knees or kneeling, which again, both of those are difficult to do if you have an epidural. That does not mean that you have to push on your back, though. We can move side to side. A lot of times we can use a push bar on the bed where we can get you up into a semi-squatting position. It's just not all the weight is on your feet. Most of it is on the bed in that type of position. So I always encourage patients to try lots of different positions and then we kind of assess which worked for them. And again, most often I saw that the position they felt the most confident and comfortable in was the position that they pushed the baby best in. Now, if you are pushing for a long time on your back and baby is not progressing, I 100% say, let's move. If you have a very dense epidural and you are not looking to squat on the side of the bed, we can still move you side to side. We can use a peanut ball. We can vary the position that we have your knees and your ankles in. There's lots of different things that we can do rather than just on your back with your feet in the stirrups. And don't hesitate to tell your nurse that you would like to try something else. Some nurses get stuck in the mindset that all patients just want to push on their back because a lot of people do find it more comfortable. You're not going to hear that opinion online very often. But when you say, hey, I'd really like to try another position, hopefully they're open to giving you some ideas. Now, here's the big one everyone wants to know. Do I have to deliver on my back in the hospital? Now, that is something that I would 100% talk with your provider about. That honestly has nothing to do with me. I don't care what position you're at delivery because I'm not the one doing the delivering of the baby. Your provider is there right at your perineum to help protect it. That's one of the things they do very most at delivery, is to make sure that baby slows down so that your perineum stretches over the baby's head, and hopefully you're going to tear less. Now, that is one of their big skills. Are they as good at it when you're squatting? Are they as good at it when you're on hands and knees? That's something to talk with your provider. I will say that hands and knees, if you can manage it, has shown decreased tears. So I hope the providers are getting a little bit better at delivering at hands and knees. It's just everything flipped. So you think that that would not be a difficult one for them to manage some education around, but it really is up to your OB or your midwife. Talk with them early in pregnancy if you're hoping to deliver not on your back. And I'm here to remind you that you want your provider to do their very best. And if that is the only way that they know how to deliver a baby, that might be the way that you want them to deliver your baby. And hopefully providers with time will get more education on delivering in different positions. Quick reminder that those 2 hours of pushing, your provider's not going to be in the room with you for the majority of the time. Usually they're only there the last 10 to 15 minutes. Some like it even less. And so you can push in all the positions you want. Nurses don't care what position you're in as long as we're not having to literally hold you up. But talk with your team to try different things. Again, open glottis pushing, coach pushing, like there's all these different ways that you can push. Try a variety of things to find out what works for you, because I am here after seeing thousands of patients deliver their baby to say that everyone is different. And what worked for Sally down the street or Becky on TikTok may not work for you. So don't plan on someone who's told you something that will end up working for you at delivery. Okay. Editor Hilary, coming to you with my Nurse Pickleball shirt on. I forgot to include something that I see a lot online that I wanted to share with you guys, and that is the fetal ejection reflex. I see people all the time saying you don't have to push at all. Your body will push the baby out for you. And it does happen. Some people are able to push really steadily enough to have the baby very quickly, but not in most people. I see so many people say online, our bodies were made to do this. And I think that is really hurtful information, because there's a lot of people who don't feel like their body is made to do it as they get into like their third hour of pushing. So if you've heard about the fetal ejection reflex, fingers crossed that it happens for you, but I don't feel like it happens very frequently or is very likely. You do feel an urge to push, kind of like when you're going to have a bowel movement, but it being a reflex where you just push the baby out immediately out of your body, not a normal occasion. Just so you guys know, from somebody who's seen a lot of people push their baby out. Now, I have a whole video on avoiding tearing at delivery, and I think that'll be really helpful. It'll be a great one for you to watch next. Some of you might be here thinking, I didn't even know I needed to push at delivery, and I'm here to tell you that I hope you get prepared for your upcoming birth. Come join me in the online prenatal class for couples, where we start in your third trimester, and we take you through all the things that like 95% of people have during their delivery up until your first few months postpartum. So we're really there to get you educated on all the interventions, all the things you can try, how to communicate with your provider so that you really get the best birth that you can. I call it the easy way to get prepared for birth, but I just hope that you'll come join me in there so that you can really get prepared for all the different things. All right, if you liked this video, please subscribe and please give it a thumbs up, because it shows other people high quality pregnancy content like this one.